Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I would like to welcome you to our provincial rounds. We are very pleased to have Dr. Graham Smith presenting today on the Maternal Health Clinic, an initiative to improve women's long-term health. Before I introduce you to Dr. Smith, I'd like to remind you there'll be time for questions at the end of the presentation. Please feel free to write your question in the chat box, and you can access the chat box at the bottom left-hand side of your screen. And as you've heard, these rounds are being recorded, and they'll be posted to the Born Ontario website. I'd now like to introduce you to our presenter, Dr. Graham Smith. Dr. Smith joined the Division of Maternal Fetal Medicine, Obstetrics and Gynecology at Queen's University in 1999. He is a maternal fetal medicine clinician scientist at Kingston General Hospital and Queen's University, who established the Queen's Perinatal Research Unit. He divides his time between high-risk obstetrics and clinical-based science research. Dr. Smith is currently professor and head of the Department of Obstetrics and Gynecology at Queen's University. He focuses his research on preeclampsia as a marker of cardiovascular disease and potential therapeutics for the treatment of preeclampsia. His primary research interests pertain to adverse pregnancy outcomes as a marker of future maternal health. Dr. Smith developed a website called the Mother's Program to improve maternal health outcomes, and I believe we'll hear more about this in his presentation today. Dr. Smith is also the past chair of the Maternal Newborn Outcomes Committee at Born and still currently sits on that committee. I also have the pleasure of working with Dr. Smith in my clinical role in the Department of MFM here at Kingston General, and I can tell you from personal experience he's an all-around great guy. So we're thrilled to have Dr. Smith present today, the Maternal Health Clinic, Who and How. So I'll now turn it over to Dr. Smith.
Thanks very much, Kathy. And Kathy and I actually shared an office for years. So I'm more than happy to speak. This is a topic that I'm particularly passionate about and have had the opportunity to speak on this in several venues recently, one of which was down at the Society of Maternal Fetal Medicine in New Orleans. They put on an entire workshop dedicated to this, really around starting to develop guidelines for postpartum assessment of women who've had complications, and we actually have funding from the CIHR to run essentially a part 2 of that workshop, which will be happening in June in Toronto, and again, really around developing guidelines. So, you know, I like to tell my patients when I see them in this clinic that our healthcare system is very much what I would call reactive. You know, essentially, you know, we wait till you have a problem, then we react to it. And very little of our healthcare system is from a prevention or, you know, health preservation point of view. And that's really the goal of the maternal health clinic. We know that what happens to you in pregnancy can potentially identify you as being at higher risk of future health issues. And we'll talk about what those pregnancy conditions are and what I think that we should be doing and what we're currently doing as it relates to the maternal health clinic. So I should start off and say that I have no conflict of interest to declare, except I do hold peer-reviewed grant funding relating to this presentation. So I've had clinical trial grants and I have operating grants from the CHR and other entities that fund the research, but in no way do I benefit financially from it. So at the end of this talk, you should be able to list the pregnancy-related cardiovascular risk indicators. Pregnancy-related cardiovascular risk indicator is a term that we've coined for the complications in pregnancy that specifically identify the woman either at being at increased risk of cardiovascular disease or identifying that that person may in fact have underlying cardiovascular risks that they may actually not be aware of. And many of the women that we see in clinic who we diagnose with some of these certainly don't know that they have them. You should also be able to develop an action plan for a patient with one of these pregnancy-related cardiovascular risk indicators so that they're basically not being identified again at the time of their next pregnancy. So we've known for a long time that preeclampsia is associated with a risk of future cardiovascular disease. So my talk is more than just about preeclampsia, but preeclampsia is a good example, and certainly where most of the data is. In fact, I like to, when I'm giving this talk, I like to remind people that this is a good example of how knowledge translation sometimes doesn't work. Because in fact, we've known the link between hypertensive disorders in pregnancy and future high blood pressure or cardiovascular disease for well over a couple of decades, but nobody has been doing anything about that. So if you look at the slide, you'll see that, in fact, if you develop preeclampsia, you have over a threefold risk of developing high blood pressure down the road. This is compared to the women who never have a pregnancy complicated by preeclampsia. You have an increased chance of ischemic heart disease, so coronary artery disease, significant increased chance of stroke, and premature cardiovascular death. And in fact, if you look at how severe the preeclampsia is and start to add other factors in, and so the example would be early onset preeclampsia plus a baby that is growth restricted, you can see the chance of premature cardiovascular disease is substantially increased. So pregnancy is essentially a stress test. How often you fail the stress test and how badly you fail the stress test probably is a marker of your future risk, and we'll talk a little bit more about that in a minute. We ran a research program called the Preeclampsia Net, and it was essentially a research study between Kingston and Ottawa that came to an end about 5 or 6 years ago. And essentially what we did is we recruited women at the time of their pregnancy when they were diagnosed with preeclampsia or had a normal pregnancy, and we followed them after delivery because we already knew some of this information relating to future cardiovascular disease. The problem is cardiovascular disease takes decades to develop, and the question was there a time frame after delivery that we could identify these people as having risks when we should intervene, recognizing that primary prevention, so before they actually develop the cardiovascular disease, is much more effective than secondary prevention. And so what we did was we essentially saw these women 1 year after delivery, 3 years after delivery, 5 years after delivery, and we did basic cardiovascular risk screening. So they had their blood pressure done, they had their weight done. We did blood tests to look at things like their lipids and their cholesterol and the sugar. And so what we wanted to do was use what we would call surrogates of cardiovascular disease, because we can't wait to see if they develop cardiovascular disease. It's going to be 20, 30 years down the road. Hopefully I'm retired by then. So essentially what we did was we looked at if these women had a condition called the metabolic syndrome. And the metabolic syndrome is a composite of cardiovascular risk. So the more of these you have, the more likely you are to develop either cardiovascular disease or type 2 diabetes. And so when we looked at the women in the preeclamptic group versus the control group in the preeclampsia network, you can see that the control patients at year 1, there was an incidence of about 6.8%. So just because you didn't develop preeclampsia doesn't mean you don't have the metabolic syndrome. And by year 3, it was essentially unchanged. However, if you look at the preeclamptic group, even by year 1, so this is 1 year after pregnancy, there's about 3 times the number of women who would be classified as having the metabolic syndrome. And certainly the table at the top identifies the components that are used to diagnose the metabolic syndrome. So elevated blood pressure, abdominal obesity, elevated triglycerides, decrease in HDL, that's your good cholesterol, and elevated glucose. By year 3, it looks like there is an increase in the metabolic syndrome in the preeclamptic group. Statistically, it's not different, and the reality is it basically looked like, if you were going to develop the metabolic syndrome, you already had it by year 1, and so none of these people actually were getting better, even though we told them this is what they had, and there was really no people who were appearing after that who had a normal finding in year 1. So, as I said earlier, primary prevention is much better than secondary prevention. And so in terms of when should we actually follow these women up, I think the ideal actually is within the first year. You could wait year 3, but all you're doing is letting the risk factors start to cause some potentially irreversible issues. So coronary artery disease would be the example. So the earlier you diagnose these, the more likely you are to be able to impact on long-term health. So our work and work that subsequently come out from other groups really suggests that within the first year is probably the time to be doing that. We did carry the study out to year 5. Essentially, it showed the same kind of thing. So earlier is probably more effective. We also looked at other markers of future cardiovascular risk, and there's different scoring systems that have been developed over the years, and I'm sure everybody has heard of the Framingham risk score. Essentially, it's used for all of us, male or female, to predict the chance of developing cardiovascular events, and cardiovascular events would be considered heart attacks, stroke, having to have your coronary arteries revascularized, so fairly bad things, obviously. And so the Framingham risk score was specifically to identify those people, male or female, who were at risk of having something like that happen within the next 10 years. And you can see the components that make up the 10-year risk score in the table. There is also a 30-year risk score and a lifetime risk score. The problem with the 10-year risk score, and we don't actually use that for our young patients, is because age is a very positive thing, at least if you're young. So, as an example, in the Framingham risk score, there's points, positive or negative points, that go with each one of these factors. And so let's say you were a 25-year-old, and obviously female, because that's the population that we're doing, but let's say that you smoked and you had elevated cholesterol and elevated blood pressure. So even though you had 3 bad things going on there, the fact that you're female and young would actually substantially reduce it to the point that no follow-up would be recommended. Well, that doesn't make any sense. We'd want to get these people to stop smoking, but we'd also want to fix their blood pressure and, fix their cholesterol. So the 10-year risk score is not terribly useful in the young population. The 30-year risk score, so age still is a factor and sex is a factor. It just doesn't have the same kind of weighting as it does in the 10-year Framingham risk score, so it's more useful. And the lifetime risk score doesn't take age into account anyway. So we think they're actually more applicable to our population. And so when we looked at our own preeclampsia net data, this graph is using these global cardiovascular disease risk estimates. At the bottom, you'll see control 10-year risk, preeclampsia 10-year risk, control 30-year, preeclampsia 30-year, control lifetime, preeclampsia lifetime. And it doesn't matter actually what risk scoring system you use, the preeclamptic women are always at greater risk of cardiovascular disease compared to the controls. The problem, though, is in the Framingham score, the recommendation is unless you have a score greater than 10, you shouldn't do anything. So you'll see that for both the preeclamptic and controls, nobody actually had a score greater than 10. So you would be sitting on these people who potentially had cardiovascular risks. The 30-year risk score, the recommendation is still 10, but you can see that we're now getting a few controls who would be identified as having a risk of future cardiovascular disease in the next 30 years. And the preeclamptics, there's substantially more. And so when we use the lifetime risk score, you'll see that over half the women with preeclampsia were actually classified as being at high lifetime risk, and about 20% in the controls. So when we're screening women postpartum, and we see them in the clinic at 6 months, and I'll talk a little bit about that in a minute, we're using these to identify women along with the presence or absence of the metabolic syndrome, to identify women who should go on to some sort of a follow-up, whether that's from a clinical point of view or whether it's recommendations in terms of lifestyle modification. So I like to use this slide. Joel Ray in Toronto sent it to me a long time ago, and I think it's very effective from a visual point of view to remind me how pregnancy is certainly a cardiovascular stress test. There's no doubt about it that pregnancy causes a lot of cardiovascular changes, and essentially what we think is that it's the maladaptation or the inappropriate response to some of these changes that helps lead to the development of complications and identifies those at risk of future cardiovascular disease. So why is all this important? Well, there was a group out of Britain who put this proposal or hypothesis together that pregnancy is a stress test and that can reveal subclinical trajectories and identify new opportunities for chronic disease prevention. And so what they identified, if you look at the red line, this is essentially somebody who, at the time of their pregnancy, you can see the red line increases such that it gets above some arbitrary threshold that they've put down here. And if you get above the threshold, then it basically identifies that you're going to have some sort of decompensation and develop a complication in pregnancy, like preeclampsia as an example. However, after the pregnancy is over, you see that these vascular dysfunction goes back to normal or near normal. In your next pregnancy, you're at higher risk of it happening again, but again, settles down after pregnancy. But if you compare that to the blue line, and though this is somebody who has an uncomplicated pregnancy or two uncomplicated pregnancies, you can see that their long-term risk of cardiovascular disease is much less, at least in terms of when it starts from an age point of view. It certainly is at a much later age compared to the red line. And so the idea was that if we could identify these women in their first pregnancy, and this was a proposal actually put together by Janet Rich Edwards, who's a cardiologist in the States, is that by intervention after the first pregnancy and things like lifestyle modification, potentially early treatment depending on what's going on, not only might we be able to prevent the future pregnancy complications, so you see in the next pregnancy, according to the red line, it doesn't get above the threshold that they've set, but it also delays or decreases the chance of the future cardiovascular disease. So it's a real opportunity or a new window of opportunity for women's cardiovascular health, but also from a future pregnancy point of view. If you look at why women die around the world, the number one cause internationally is cardiovascular disease. It passed cancer as the leading cause several years ago, something that the Canadian or the Heart and Stroke Foundation of Canada has been pointing out for a long time. And so it's important that people understand that and identify that. And the interesting thing in women is that it presents typically different than it does in male. And so women tend to be underdiagnosed, and at the time that they present, when they have their heart attack, they tend to be sicker than males do. And in fact, some of the times they present with a heart attack because they present often with different signs and symptoms. It's underdiagnosed as well. So pregnancy is a real opportunity. But it's not just preeclampsia that's the complication. Joel Ray did a study using Ontario data, and what he did was he looked at women who, at a period of time after pregnancy, had a hospital visit and linked it back to what happened in their pregnancy. The hospital visits he was specifically looking for was if they had things like a heart attack, a stroke, they had been in because they were having abnormal rhythms in their heart, a bunch of things like that. And he looked at what happened in their pregnancies, and it was what he called the CHAMP study. And CHAMP was an acronym for cardiovascular health after maternal placental syndrome. And the placental syndromes that he identified were preeclampsia or gestational hypertension, if you had an abruption, if you had a growth-restricted baby, if you had a preterm birth. So things like that are associated with future cardiovascular disease. There have been many studies since Joel's study, which was in the early 2000s, that really identified the same kind of thing. So when we put all these together, these pregnancy-related cardiovascular risk indicators, who would be the ones that should be seen, and in fact, these are the ones that we see in our clinics, and those would be the preeclamptics, plus or minus whether they get HELLP syndrome or eclampsia, the gestational hypertensives, gestational diabetes, and certainly the Canadian Diabetes Association does recommend that all these women with GDM have a follow-up glucose tolerance test within about 6 months. Unfortunately, that rarely happens, even though it's the recommendation. Erin Keeley up in Ottawa has done much work in this area, really identifying that if you gave reminders to the patient and or the physician, then you increase the chance of it getting done, but the reality is it's still not 100%. So if you could get these people into some sort of follow-up, that would obviously be ideal. Gestational impaired glucose tolerance. So if you have one abnormal value on a 75-gram oral glucose tolerance test, it's basically now classified as gestational diabetes. If you have a growth-restricted baby, either less than the 5th percentile or by definition less than 2,500 grams at term, puts you at increased risk. Idiopathic preterm birth, so you go into labor for no specific reason, or if you have a placental abruption. So these are the pregnancy-related conditions that really can be markers of future maternal health. I wrote a white paper with George Soddy. Dr. Soddy is a maternal fetal medicine specialist down at the University of Texas Medical Branch, and basically the group was presenting this to the White House with the goal of trying to set up some sort of follow-up. I'm certainly no expert in the American healthcare system, but my understanding of one of the things that Obamacare is trying to do, recognizing that about half the Americans, especially those who have, are low socioeconomic status, have no medical coverage. When they're pregnant, they do have Medicaid, and that covers them for a certain number of visits during the pregnancy and up to 6 weeks postpartum. The problem is, if you develop one of these complications, you don't want to be seeing them at 6 weeks because some of the pregnancy-related changes are still there. You want to be seeing them maybe at 6 months or 12 months. But unfortunately, these people with Medicaid would have no coverage to be able to do that. Obamacare, basically, part of it identifies that if you develop some sort of a complication, and it's not just for pregnancy, that is felt to be a risk of future health, then you should have some sort of a follow-up. And so the goal of the group in the States is to use the complication in pregnancy to get them coverage, to get some sort of follow-up care done. So I worked on this paper with George Soddy. They presented it to the White House, and I don't know if they actually know where that's going to go at this point, but hopefully, or they're hoping that it's going to translate into improved care for the women down there. So we've been running what's called the Maternal Health Clinic now for, I guess, about 4 years. We've published much on the clinic. It's internationally unique. There are people who are trying to set up these clinics now, not just here in Canada. In fact, Kara Nuremberg in Ottawa has been doing a similar clinic. There's Karen Fleming in Toronto at Sunnybrook is looking at setting one up. They're looking at setting one up in Calgary, certainly Montreal, they're looking at it. So there's a whole kind of movement now from a health preservation disease prevention point of view to set up similar clinics. And we've published, as I say, much on the clinic. It took us a lot of kind of bumps in the road to start with to get it running as we like. We created a whole bunch of documents that we use for data collection and follow-up with the women. And so all the stuff has been put into a couple of publications in the JOGC. So anything that people want to get in terms of how to set up a clinic or what specifically needs to be done, they can get from that publication. But the other thing is, we do, as Kathy mentioned at the beginning, I did set up this website. It's called the Mothers Program. Mothers is an acronym for Mothers Health Through Education, Research, and Screening. And if you go onto the Mothers Program website, which is www.themothersprogram.ca, and go on to the After Delivery section, you'll see that there's a whole part on the Mother's Program Clinic, the postpartum maternal health clinic handbook we created for health practitioners to set their own clinics up with all the forms that we use. People are more than welcome to obviously download them and use them as they see fit. Hopefully it'll be more smooth sailing to set up such a clinic compared to what we had. And it was really because we were flying by the seat of our pants when we first got this going. So when we set the clinic up, I thought I'd better have an idea in terms of how many people I might see in the clinic, because it's basically just me. And so I used the Born system, yay Born, and so I looked back at Born Ontario data from 2005 to 2009. You can see at that point there was about 650,000 deliveries in the system. When we put in the pregnancy-related cardiovascular risk indicators that we could, or that were at least collected by Born, so preeclampsia, gestational hypertension, gestational diabetes, IUGR, preterm birth or abruption, you can see that about 20% of the entries, so 20% of the women, had at least one of those complications. So not an insignificant number potentially would be referred to this clinic. When we first started doing the clinic, I spoke to the physicians and the GP obstetrician, or GPs doing obstetrics, and the midwives, and our residents, and said, okay, if any of the patients who deliver has one or more of these things, please refer the patient to this clinic. We're going to see them at 6 months after delivery. And I think people probably remembered to do that in the first week, and then it was forgotten about. So we went back to the drawing board, and then we came up with the idea that on our standard postpartum delivery order set, and this one here is specifically for vaginal delivery, but the same thing is for cesarean section, the very first thing on the very first page of the order set is a consult to the maternal health clinic, and you can see that the actual pregnancy complications that would be indications for a referral are listed there. And so that actually improved things substantially. Essentially, nobody was being missed at that point. Even the medical students were able to fill that out correctly. The part of the problem, though, was patients weren't always being told that this was an association in terms of complication in pregnancy and future health risk. And so when my secretary was sending out the packages with information about the clinic and the purpose of the clinic, which she was sending out at about 3 months, people were totally unaware of this, and we had some women who were really panicky, phoning up saying, what, I'm going to have a heart attack? And some who, they were just so busy with their baby, they were totally uninterested in it. So we then decided, okay, well, we better talk to these people before they ever leave the hospital. They've been referred, but we should at least inform them. And so we now have a package of information that we provide to them at the time of discharge, but we speak to them before they go about the purpose for follow-up from a clinical point of view. And so while we are using it certainly from a research point of view, the clinic was set up as its primary reason for really as a health service to these women, really from a future pregnancy point of view, but also their long-term health point of view. And that's actually worked out very well. So the way the clinic works, patient delivers at Kingston General Hospital. They're screened by the medical staff. You can see there's the relevant complication list that is taken right from our postpartum order set. If the patient has developed one or more of these complications, they get a referral. There's a referral form that's completed. Patient is counseled by the medical staff, and part of that referral form is sent to my office, identifying that it's actually being discussed with the patient. My secretary sends out an appointment package at 3 months. They get a call from my office about 2 weeks after the package to make sure that they understand what the purpose is, in case they have any questions right then. And then they get a reminder call about the appointment about a week before the appointment from my office. And in fact, the hospital also does a reminder a couple of days beforehand. And then they come to the maternal health clinic. or at least they're supposed to. So at the time of the appointment, there's a nurse by the name of Michelle Roddy who works with me, and she actually does all the kind of the data intake, if you will. She does a complete history, and particularly we're interested in family history because a lot of the risks certainly are genetic, and we see a lot of significant family history in these women in terms of, you know, first-degree, secondary relatives who've had heart attacks or have hypertension or have type 2 diabetes or whatnot. At the same time that we're doing that, we also do a physical exam, specifically focusing on cardiovascular related things. So their blood pressure, we want to look at their BMI, we do their waist circumference, and then we give them a requisition for blood work that's really looking at, again, cardiovascular risk. So that would be your lipids, your cholesterol, triglycerides, fasting glucose. If you had gestational diabetes, then we do the 75-gram oral glucose tolerance test as recommended by the Canadian Diabetic Association. And then there's blood work relating to something called CRP, which is a marker of inflammation, which is associated with cardiovascular risk. And we look at urine for albumin to creatinine, which is a marker of endothelial dysfunction as well. And that usually it's supposed to be fasting, so they're not usually doing it at the time they come to clinic. They do it usually within the next week, and then it takes about a week for me to get the results. We put it all together, and if we haven't got blood work within the first kind of 6 weeks, you can see that there's reminders that get sent out. We send out 3 reminders, and if after the 3rd reminder we still haven't gotten any results from them, we basically close the chart, send a note to the patient, but we also send a note to the family doctor with the recommendation that the next time the patient shows up for whatever reason, that they should consider sending them for the blood work at that time from a health screening point of view. Once we actually receive the results, there's one of my research personnel, her name's Jessica Pudwell, actually puts it all together for me. And there are these different cardiovascular risk scoring systems. So she calculates this all for me. And then once the chart is kind of complete from Michelle and Jessica's point of view, it shows up on my desk for me to dictate a note. And I actually send a note to the patients specifically, because I tell them that, you know, if I need to motivate somebody, it's not the family doctor that I need to motivate, it's the patient that I need to motivate. And so at the time of the clinic, after Michelle has seen them, and we do have at least their blood pressure and some of the other markers or measures of health, I do sit down and speak to these women at length about lifestyle modification, you know, specifically looking at dietary things and physical activity. And one of the things that I do recommend to everybody who comes to the clinic is that they get themselves a pedometer. There's a recommendation that we all do about 10,000 steps a day. This past Christmas, I got my whole research group, Kathy included, Fitbits. And Fitbits, essentially, it's a fancy pedometer. But essentially what it does, it records your daily step counts. It happens to upload onto the computer, so I can see what everybody in my group is doing that day to see if they're slagging off or whether they're actually up and active. So as an example, it's just after noon. I've done almost 6,000 steps today towards my 10,000. And I can tell you that we hear from patients all the time how motivating their pedometer is. It doesn't have to be a Fitbit. In fact, Fitbits are relatively expensive. You can get cheap pedometers. But we had a patient email us at one point. She said that what she would do is she would look at her pedometer at supper time, and if she hadn't met her step counts, it was kind of like, okay, we're all going out for a walk after dinner. And that's something that obviously I think the whole family can do. I think that maternal health often is a reflection of family health. So, you know, I think it's a way to motivate people. But it's also a way to get an overall assessment of activity. We had a patient email to say that She couldn't understand why she wasn't getting her steps. She was going to the gym twice a week, and it turned out that, apart from the twice a week for an hour that she was going to the gym, she was essentially not doing a whole lot else. So it can be a bit of an eye-opener in terms of how active or inactive that you are. So in the letter that I send to women, I reinforce what we talk about in terms of lifestyle modification. What I tell them as well, though, is that if they are identified as being high risk for future cardiovascular disease, whether that's because they've got the metabolic syndrome or because their cardiovascular risk screening score is elevated, then I actually refer them on to see one of the cardiologists here who works with me. And what she does, she actually reviews them, and if she feels that it's appropriate, she refers them on to our cardiac rehab program. So we've been very fortunate that the person who runs our cardiac rehab program has agreed to have these essentially young women come into the program. So, we have the 25-year-old young woman with her baby sitting beside the 70-year-old guy who's there for secondary prevention because he had his heart attack. So it's quite a dichotomous thing. The woman's there for primary prevention, the elderly man's there for secondary prevention. And so the goal is, again, to prevent the long-term health problems. If the cardiologist, her name is Raveen Pal, and if she feels that it may not warrant referral to the rehab program just yet, she follows them up to see what happens when, for instance, they lose the remainder of their pregnancy weight, or they aim to lose the remainder of their pregnancy weight. So this is a table from a manuscript that's just coming out in the American Journal of OB-GYN with the first essentially year and a half of data from the clinic. So I've broken down the table into the maternal health clinic analysis group. So those are women who actually showed up to the clinic, and the other column is women who were invited to come to the clinic but decided not to show. And you can see the conditions: preeclampsia, gestational hypertension. They make up about a third of our population that come. Gestational diabetes, about a third, and then abruption, preterm birth, IUGR. All of those may be associated with some of the hypertensive disorders as well. You don't have to read this whole long table, but suffice it to say, these are the different kind of cardiovascular risk markers that we're screening for from a biochemical point of view. And if you look at the data, essentially what you'll see is that the number of women, for instance, who have what would be classified as borderline hypertension, or in fact hypertension or blood pressure high enough to treat, is about 40-45%, both for systolic and diastolic. If you look at things like cholesterol, it's about half the population, whether it's your total cholesterol or some of the other markers. We've only had one woman come through who actually had a positive glucose screen, but you'll see some of the other things that we do. So it certainly looks like we're able to pick up these factors in this group of patients. So I think that the reality is it's an effective way to identify women who might have underlying cardiovascular risks. So when we look at the different scoring systems, again, this is the column A is the maternal health clinic group. Column B is actually the preeclampsia control group, so we're using that as a control population. They were seen basically at the same time postpartum. We don't see low-risk women in the maternal health clinic, so we needed a control group. And I put the preeclamptic group in there as well as a comparison, because the maternal health clinic group is a very heterogeneous group. So it's everything, as I said. It's the preeclamptics, the gestational hypertensives, the diabetics. It's very heterogeneous, and I wanted to see how it came out in comparison statistically to the pure preeclamptic group from our previous study. And you can see, if you look at lifetime cardiovascular disease risk, so in the first column going down, 30-year cardiovascular risk or metabolic syndrome, column A versus column C, which is the purely preeclamptic, they're exactly the same. So it really identifies to me that it probably doesn't matter what you have of these risk indicators, they all put you at higher risk. When we compare column A to column B, which is the control group, you can see that there's a significant difference in the lifetime risk, the 30-year risk, and certainly the incidence of metabolic syndrome. So again, I think that how we're setting the clinic up and the people we're identifying who are coming to the clinic, we're really identifying the high-risk group that's being done from a clinical point of view, and in this situation compared to a purely research preeclampsia group. So I hope you'll appreciate that certain pregnancy complications are reliable markers for underlying cardiovascular risk. As I said earlier, we've known some of this information for a long time and haven't done anything about it. But we do know that early identification and treatment of cardiovascular risk factors can prevent long-term cardiovascular disease. The numbers in Canada are that it costs the Canadian government somewhere in the order of about $80 billion a year from a healthcare point of view. And the Canadian Cardiovascular Congress a few years ago identified that probably about 80% of that was preventable through risk identification and lifestyle intervention, recognizing that lifestyle change is often hard to actually do. So I'm going to end with a couple more slides after this, but I do have a big research group who work with me. Kathy's not part of my research group anymore. She's purely working clinically with Born, but obviously she's part of this process as well. The Mothers Program website, we created as basically a reliable source of information for women, anywhere obviously, but it's become well used by women in Ontario. The last time I looked at it, we were getting about 8,000 hits a week, most of which were from Ontario sites. So it's useful information. Basically, I went through and created all the information I talked to patients about in the antenatal 1 and 2, and we're continually adding stuff to it. The last thing I just want to mention is we are in the process of creating a web-based or smartphone-based application called the HIP program, and HIP is an acronym standing for Health Improvement After Pregnancy. And essentially, it's a mobile website, physical activity and diet program. The whole program has been created. We've just finished some of the short video clips that we do from a physical activity. I'm working with a woman in town by the name of Tracy Smith-Bayak, who runs a program for pregnant and postpartum women. And I am working with the dietary counselors here at Kingston General Hospital, where we created a whole lot of short video vignettes, if you will, that are going to be built into this mobile website, which will be all accessible from either your computer or your smartphone. And so once it's completed, we'll actually use this from a clinical trial point of view, but the hope is that, not just in our high-risk patients to decrease their cardiovascular risks, but potentially in the end, we could open this up for free to all postpartum women, because the reality is, I don't think we do a good job telling women or informing women how to lose weight postpartum. And I can tell you, having heard this from lots of patients, if they don't lose all the weight postpartum and they go into their next pregnancy heavier, they start this cycle so that at the end of their childbearing, they're at a weight much higher than they had after their first pregnancy. It's better to lose the weight after each pregnancy. Certainly it decreases the chance of complications in the short term and the long term. So I'm going to stop there. I think it gives us a few minutes for questions. I'd be more than happy to entertain questions. And as I said earlier, you can get information about the clinic and all the different forms that we use, either off of the Mothers Program website or through the article that we wrote in the OB-GYN journal, the Canadian OB-GYN journal, that was published last fall. I'm also happy to, if anybody has questions at the end of this, if they want to send me any questions by email, I'm certainly happy for that to occur as well. So thanks very much for listening.
Thank you so much, Dr. Smith. That was a very, very interesting presentation. Pregnancy offers us a real opportunity for heart disease screening and intervention. So I'd just like to remind everybody on the bottom left-hand side of your screen, there's a chat box there. Feel free to write your questions in, and we'll have Dr. Smith answer those.
Maybe as we're waiting for questions, I'll just, my view of this, I'm an obstetrician, and seeing women 6 months after delivery is really getting out of my comfort zone. So I view myself in this situation as really the starting point. So once they come to my clinic, they don't have follow-up with me in the clinic per se, though I have seen some of these women in their next pregnancies. So I think that in the long term, the people who are going to be running these clinics are probably going to be family physicians, as an example, and certainly Karen Fleming at Sunnybrook is a family physician interested in this. Kara Nuremberg is an internist, and I think the reality is it's probably going to be general internal medicine that's going to be running these kind of clinics, or those who are interested specifically in obstetrical medicine that will be running these clinics. But it'll be us, either as the obstetricians, the family docs doing the obstetrics, or the midwives, who it'll behoove us to identify these patients who should have the follow-up.
There's no questions in the chat box yet, but I had one. So for the women that are referred to the cardiac rehab programs, is there a way that you still follow those women, or that you get outcomes on what happens to them?
Right, so that's a good question. So we are tracking them. Basically, their follow-up either during or after the cardiac rehab program is with the cardiologist, and communicated with the family doctor. So I'm kept in the loop, and we do have that information. There's not enough information yet for us to put together to say, how effective, was that in terms of, did it help these women to, for instance, lose weight, or did it help their blood pressure to come down? We certainly know that cardiac rehab programs are very effective, certainly in the population that they're usually used for. But there have been a couple of publications by groups in the Netherlands. They're very interested in this area as well, looking at lifestyle intervention postpartum, because the argument is always just because you can identify it, these women and identify they're at risk, can you actually make a difference? Well, I can tell you the two recent articles by the Dutch group, putting women through what I would classify as not terribly intensive exercise programs. Now, certainly they were monitored, and there was, a trainer there and that kind of thing, which is not, available for everybody. And certainly, one of our goals with the HIP program, the smartphone-based app, is that, it'll be available for everybody. It won't cost a thing. So we want something that's generalizable to the whole population. Anyway, the studies by the Dutch really identified that you can actually improve not just weight, but some of the metrics of cardiovascular disease. So they were looking at not just blood pressure, but they were looking at VO2 max and blood vessel reactivity and how thick blood vessels were. So very intense testing that they were doing, with a relatively short and what I would say not terribly intense exercise program. But I think it's important that we continue to look at ways to improve that are applicable to all women.
Thank you. There is a question here. It says, what's on your wish list for one key born data element that we don't currently collect that might make a big difference to helping with long-term cardiovascular health?
Yeah, that's a good question, Anne. I think the reality is we collect them all. Born collects them all, and Born, the database, I'll put a plug for the database because, I've used it for research purposes and clinical purposes. It's extremely robust. The thing I think that will be helpful down the road in terms of moving forward is not necessarily collecting more data, but using it to identify the people who should have the follow-up, and if we were ever in a position where we could actually send out, patient-level reminders, either to the patient, certainly to the primary physician, I think that's where it's going to make a difference, and the reminders would be, your patient developed this complication, this is what the recommended follow-up should be. And so again, the research that Erin Keeley did in Ottawa with gestational diabetes really identified that if you wanted people to get the follow-up screening that's recommended done, you send reminders both to the family doctor and to the patient, identifying, one, that it should be done and what should you be doing. Patients get busy with their kids. Family doctors, have busy practices, and so some of this stuff gets forgotten about. And I say it's a real opportunity. So I don't know that we need to actually collect other information, but it'd be nice down the road if we had a way to send out reminders, I guess. Red flags, if you will.
Thanks, Graham. And I know, just speaking personally, it is that time in a woman's life, having done that, been there, not doing it again. It's so busy, and your focus, stays so much with that baby, and that continues, as that child gets older and older. And I find for myself, I've only come back to looking after my own health later in life.
Yeah, no, I agree. And I think, one of the reasons that we picked 6 months to see these women after delivery, you have to wait long enough so that the effects of pregnancy, at least, on the cardiovascular system, like, pregnancy changes your cholesterol, lipids, that kind of stuff. We want all that settled back to whatever their new normal is, or whatever normal is for them. But I think that the other thing is, we recognize that most women, in terms of losing weight postpartum, don't lose it in the first 6 months. In fact, they lose it, more between 6 to 12 months. In fact, they're so busy with their kids or their new baby in the first 6 months that they don't even think about themselves often. So any weight they lose often, is from nothing that they specifically have, gone out and done. However, once you get to 6 months, people start to, think about themselves, as they're getting into more routine. So it's an opportunity to try to, make intervention or make suggestions so that, the next 6 months they can increase whatever they need to do to lose that weight as, a very good, primary prevention from cardiovascular disease point of view. And the reality is, there's no secret to how you lose weight. It's all about, how many calories you put in, how many calories you burn off. It's not easy to do for some people, no doubt about it, but there's no secret in terms of how it specifically is best able to be obtained.
Mm-hmm. There's another question here from Bourne, actually. Is there an interactive component to the program where women would input data about their diet or exercise?
I assume the question is relating to the HIP program that we're creating, and the answer is yes. What happens is, every week, the program is going to last for 3 months, and every week there are reminders. Sorry, let me step back. Every day there's a reminder to the patients or these women to do their steps and to log their steps. And there's also information that gets sent out about what the recommended physical activity for the day is. So we do have a short core workout, kind of core exercise, balance type exercise that they'll be reminded that they should be doing 3 or 4 times a week. And it literally takes 20 minutes. So it's kind of like the old 20-minute workout type thing, but it's more core type exercises. But when women enter their information, so there'll be things like, how many steps did you take today? Did you do the recommended exercise program? All that stuff gets automatically uploaded to us. So we basically real time are going to be able to see what people are doing and are going to be able to give them feedback. Excellent job today. You're at 8,000 steps. Next week, you should be aiming for 9,000 steps or whatever. But we will also be asking. There's reminders that go out in terms of dietary things, but we will also be asking in terms of, what did their diet include, and periodically they'll get, a reminder to say, please fill in this form to give us an idea so that we can calculate how many calories you're taking in, or that kind of thing. So there is a component of data collection relating to both physical activity and diet. I always like to not use the term exercise. A lot of people get intimidated by the term exercise. I think physical activity is, people think exercise is running and biking and swimming and that kind of stuff, which obviously it is, but physical activity can be as simple as walking.
That's a good point. Thank you.
Well, I think and you can comment on it as well, the use of the Fitbit as an example is extremely motivating. I can tell you that, I'm the type of person who gets out and exercises on a regular basis, but if I'm not at my 10,000 steps, before bedtime, it's kind of like, what, maybe I'll just get on the treadmill, or maybe I'll just walk up and down the hall to get those last 100 steps or whatever. So, it's extremely motivating, which I think that's the key to success. Why do running programs like the Running Room work? Well, because they have groups that do it together, and you feel motivated by getting out, and you feel that if you don't get out, you're failing the group. And this is the same kind of thing. I think that having a group or a partner to do the physical activity with is extremely helpful.
I totally concur with the motivation piece on Fitbit to see what all your group is accomplishing, and you definitely want to stay up. I don't see any other questions in the chat box. So with that, I think I will thank Dr. Smith for that excellent presentation and helping us recognize pregnancy-related cardiovascular risk indicators and understand what type of care is required for this patient post-birth. And I think we all saw that pregnancy is a window to future health care. So thank you so much for that. I'd like to thank everyone for attending today and the questions that you posed. I'd also like to tell you that our next Born Provincial Rounds will be May 15th, and our speaker will be Dr. Denise Harrison. Dr. Harrison has been researching the calming effects of sucrose in infants and children when it comes to relieving them from painful procedures such as needles. So please join us for her presentation, Be Sweet to Babies. An announcement regarding that presentation will be coming to you. Also like to mention that for those on a little bit early, we had a very first slide up that talked about our Born conference. So Born is hosting a 2-day conference, the right information in the right hands at the right time, using data to improve maternal child care and outcomes. It will be on February 26th and 27th, 2015 at the Fairmont Chateau Laurier in Ottawa. Call for abstracts is now open, and the Conference Program Planning Committee invites you to submit an abstract for presentation. So please visit our conference website for more information, and it's bornontarioconference.ca. So once again, thank you to Dr. Smith, and please come back for our next rounds booked May 15th.
Thanks, everybody.
Bye for now.